Hey everyone. So this next topic is about preload. I went over preload more in depth in the previous video, but this is more talking about what increases it, what decreases it. Okay. So just to recap now, preload is the amount of blood that fills the left ventricle or the right ventricle. But anytime they talk about preload on the usmle, it's probably about the left ventricle and the systemic, the arterial system. And when do we measure preload? At the end of diastole, right? Okay, so now, if you look at a heart, and I'm just going to draw a ventricle here, okay, and this is the amount of blood filling it, okay, this is my left ventricle, okay, this is all blood, okay, what increases preload and what decreases it? Okay, so what would increase the amount of blood in my left ventricle? Well, in order to actually answer that question, I'd have to think about when do I have preload? When does the ventricle, actually fill with blood? It's during diastole, right? So if I increase the amount of time I spend in diastole, basically, if I relax the ventricle and if I give it time, to fill, that would actually increase preload, right? Because I'm allowing it to fill with blood at that time. The ventricle's relaxed, it's filling with blood, it's not contracting. So how can I increase the amount of time I spend in diastole? By slowing down the heart rate, right? If I slow down the heart rate, I'll spend more time in diastole. How can I slow down the heart rate? And what determines the heart rate? The SA node, right? And what does the SA node rely on? The sympathetic and parasympathetic pathways. Okay, what does the sympathetic do? It increases the heart rate. What does the parasympathetic do? Decreases the heart rate. Okay, through what type of receptors? Muscarinic receptors. What transmitters does muscarinic receptors use? Acetylcholine, right? Okay, just reviewing some random things here. All right. So if I increase the parasympathetic system, activate my muscarinic receptors, that will actually decrease my heart rate. Okay, so on a side note here, what does atropine do? It's a muscarinic antagonist. So if it's a muscarinic antagonist, what is it going to do? If activating a muscarinic receptor decreases the heart rate, and antagonizing it will block it completely. So what will basically win the tug of war? The sympathetic system. So what will happen to the heart rate? It'll actually increase with atropine, right? And when do you give atropine? When patients have bradycardia. Okay? Alright, now getting back now to preload. We said that decreasing the heart rate, giving him more time for diastole, giving the ventricle more time to fill with blood. The important thing here that I should actually mention is that when do the coronaries fill with blood? This is actually a very common USMLE question. Right here. Tons of USMLE questions from here. And the answer is actually diastole. Why? Is because if you look at the muscle here, the myocardium, and you look at the coronary arteries that are actually on it, this is what they actually look like. This thin strip here is the coronary. This is the myocardium. If my myocardium is contracted really tight, and when does it contract? During systole, right? What's going to happen to the coronary? It's going to get squeezed, okay, because the myocardium is contracting. And when the coronary gets squeezed, what's happening to its radius? It'll decrease, right? Because it's being squeezed in. The radius will decrease. So will it be easier or harder to get blood through? Harder, right? So that's why the coronaries always fill with blood during diastole, not systole, okay? So yeah, that's one example of what can increase my preload is diastole, increasing the amount of time I spend in it by the parasympathetic system, decreasing the heart rate. Okay, what's another thing? Well, where does the blood actually come from? The venous system, right? Okay, and a lot of blood is pooled where? In your veins, in your lower extremities, right? Okay, and if it's pooled all down there in the lower extremities and it stays down there because of gravity, what can help it come up? By laying down, right? Or going in the Trendelenburg position, putting your legs up, elevating the lower extremities. What does that do? It brings all the blood, basically, that you have from your lower extremities up to your right atrium, right? Okay? Now let's draw that again. Okay. Okay, this is my right atrium. Okay, and this is my inferior vena cava, right? Where is the blood coming from the inferior vena cava? Your lower extremities, all of your veins, joining with the portal vein, etc., to bring blood all through here, okay? So elevating your lower extremities will actually increase my venous return. Anything that can increase venous return will increase my preload. Does that make sense? The more blood coming back into my veins will cause more blood to go into my right atrium, more blood to my right ventricle, more blood then to the pulmonary artery, from the pulmonary artery to the pulmonary veins, my left atrium, down to the left ventricle, right? So again, anything that can increase venous return, and elevating the lower extremities is one of them, right? What's another thing that can increase venous return? Squatting, right? Same thing. Laying down. Okay. And the one actually really interesting thing to know is that what happens when your brain becomes hypoxic? When your brain's not getting enough oxygen and you start feeling really lightheaded, right? When you become hypoxic, you get lightheaded, right? And at a certain point, what will your body do if it becomes more hypoxic and more lightheaded? You will eventually faint, right? You'll faint. What happens when you faint? You black out and you lay down. Lay down flat, okay? When you faint and lay down flat, what's happening to your venous return? It's increasing. This is actually a mechanism that your body has to increase venous return. When it senses your brain is hypoxic and it's saying, hey, I'm not getting enough oxygen, you know what? Let's just black out, faint, and have this person lay down flat. That increases venous return. You know, and when you're interns and in the middle of the night you get called for your patient who is hypotensive, feeling dizzy, lightheaded, etc. What's one thing you can do is actually just elevate their lower extremities and bring their legs up to, get venous return. Anyone at the gym who's feeling lightheaded, nauseous, or if they're not hypoglycemic and if they're hypotensive, have them lay down or put their legs up just to help increase venous return. And again, increasing venous return will increase preload. Increased preload will increase my stroke volume. If I increase my stroke volume, I increase my cardiac output. If you increase your cardiac output, more blood to your coronaries, more blood to your brain, more blood to all of your organs, right? Okay, does that make sense? All right. Okay, now one more thing that increases venous return. Exercise. How does it do that? Well, if you look at the muscles in your lower extremities, your quadricep muscles, all the muscles in your legs, it kind of looks like this. If this is muscle, this would be like a vein in there. Okay? And again, muscle. Okay? So what happens when you're actually exercising? Your muscles are contracting. Okay? They contract in one or the other direction. When they contract, what are they doing to the veins here? They're actually squeezing the veins. When I squeeze the veins, what's happening? The blood is being pushed in one direction, and that's up towards the IVC. Okay, does that make sense? Why does that make sense? Because all the veins have valves in them, and they're all one-way valves. What does that mean? That means the blood can go up in one direction, but it cannot go back down. The valves won't let that happen. So when the muscles contract against it, the blood will go in one direction. That's up towards the IVC. So when your quadriceps, your gastrocnemius muscles, all those muscles are contracting and they're squeezing the veins, they're sending blood up through the IVC and into the right atrium, and they're not letting any blood down. And this is actually one of the very, very common USMLE questions where they talk about, they'll even show you a picture of someone with varicose veins. What are those? Veins that really stand out and are prominent in your lower extremities, and I'm sure you've seen those in some patients. And they ask you, what is the defect? What is the physiology or the pathology behind these varicose veins? The pathophysiology is these valves here, okay? They're defective. They're not working well. And if they're not working well, can they hold the blood going in one direction? No. They are basically defective, so they're loose. So there's a hole in them, right? So the blood can go back. That's why they get really, really swollen veins in the lower extremities, edema in their lower extremities, etc. Okay? So again, not everyone with lower extremity edema has congestive heart failure. They can have lower extremity edema because of varicose veins, okay? That's actually a really, really good point to actually know, is because they can say, oh, this 55-year-old male comes in with lower extremity edema, etc., but they won't mention shortness of breath, they won't mention orthopnea, they won't mention paroxysmal nocturnal dyspnea, anything like that. But they might just show you a picture of these veins and ask you what's going on, and you might, immediately jump to CHF, and that will probably be letter choice A to trick you, but don't go for that. Okay. Getting back now. Exercising, increasing venous return, increasing preload, increasing stroke volume, etc. Okay. Okay. So another thing that actually increases preload is are transfusions. Okay. What do I mean by that? It could be packed red blood cells. It could be normal saline infusion, etc. Anything like along those lines will increase basically my blood volume. Okay. All of those things increase blood volume. And if I'm increasing the volume of blood in my circulatory system, I'll get increased venous return. And by that, again, anything that does that will increase my preload. Okay. Really simple reason why we always give patients with who are hypotensive or bleeding, in the trauma room, etc., normal saline or basically IV fluids, just to increase their preload, increase venous return, cardiac output, and oxygenation. Okay. Now, there are actually a lot of USMLE questions which will actually test this really simple physiology concept. Okay, what they'll do is they'll give you a really complicated paragraph, something about research, something about knockout mice, etc., etc. But at the end of the question, they'll just come and ask you which of the following will increase the preload or increase venous return, increase etc. They'll ask you something along those lines, and what you'll have to do is actually think of one of these. What it'll come down to is you'll have to think to yourself, which one of these will increase venous return? And you'll have to think squatting, laying down, exercising, transfusions, etc. Okay? So always remember that. Always make a question out of everything you're studying. Okay, so we talked about what can actually increase preload. Let's talk about what can actually decrease it, okay? So let's draw our same diagram here. Okay. And again, we have the IVC coming down, right? Which makes up all the different veins. Okay. Okay, all the different veins. And this is a rough drawing, basically, just to demonstrate what I'm talking about. Okay. What are some things that can decrease preload? What do I mean by that? How can I decrease venous return? Okay, the one thing that actually can be really, really helpful is whenever you think of the heart and the IVC and all the veins there, think of it as something that's just basically straight with gravity working. A pipe just like this, okay, going into a tank here. That's exactly the way all the veins are and the tank here. Now, getting the blood up here is all related to gravity. Okay, like I said before, is that when you lay down, what happens to gravity with this blood in the IVC? There is no gravity, right? Because you're laying down flat. It's like this now. And is it hard for the blood to go back? No, it can really easily go back to the heart. Okay, but when you're standing up, gravity has to work itself. The blood has to work against the gravity to get into the right atrium. Okay, now standing up will decrease preload. So standing up will decrease venous return. That's why most people, especially elderly people, when they stand up quickly, they get dizzy, right? When they stand up quickly, they get dizzy. Why? Is because their bodies, when you stand up, immediately stand up, what do your blood vessels do? They constrict. Why? Is because what happens when you stand up? Gravity hits, and all that blood that was in here kind of goes back down, like for a second. And your body rushes to kind of say, hey, this blood pressure is dropping. We need to get it back up. So what does it do? It constricts through alpha-1 and other receptors, okay? When it constricts, it maintains the pressure. People who are elderly, people who have especially Parkinson's too, their sympathetic response is not that good. And what happens? It takes them a little while longer. That's why you always tell your elderly patients to wait a couple seconds before walking. Don't immediately stand up and start walking, because that's how a lot of falls happen, right? Okay, and it's all because of gravity. Gravity decreases preload. The other thing that decreases preload and decreases venous return is Vno Dilation. Okay, venodilators, right? What's one of the biggest ones? Nitroglycerin. Okay, what is that doing? It's dilating the vein here. So if my vein looked like this before, if that was the radius before, I'll show you now. If I gave a venodilator, imagine this happening. It just got a lot more wide. The radius is more wide now, right? And if it's more wide, is it easier or harder for blood to come back up here? It's more difficult. Okay? Really difficult, right? Because if it's more narrow, the radius is smaller. It's a lot easier for the blood to maintain pressure and go back up. But if it's wide like this, what's going to happen? It's just going to stay down here. The blood's going to stay down here, and it can't create enough pressure to come back up. Okay, so when you give nitroglycerin, what happens? You decrease venous return, and when you decrease venous return, what do you do to preload? You decrease preload. Okay, this is getting to a point now of actually nitroglycerin and its role in myocardial infarctions, right? Why do we always give nitro to patients who have MIs? Who are having heart attacks, who are having angina type pain? Well, this is the reason why, okay? Like I mentioned before, the Starling curve says what? As you increase preload, what do you do to cardiac output? Increases, right? Why? Is because the preload stretches the heart, right? And when you stretch the heart, what does that do to contractility? increases contractility. Stretching the heart increases contractility. When the heart senses, the ventricle senses, hey, I have a lot of blood in the ventricle, it says, you know what, I need to get rid of it, so it contracts stronger. Okay? That's why when you increase preload, you increase cardiac output. Not only, yeah, there's more volume there, so you have to send more out so because you're increasing your stroke volume, but also because it contracts stronger. Now, when it's contracting really strong, is it using more oxygen or less oxygen when it's contracting that much? More, right? Because when your muscle, your myocardium is contracting a lot and using a lot of power, it needs a lot more oxygen, right? If it's using up a lot of oxygen, is that good in a case when you have an MI or bad? That's kind of bad because you know what? If one part of my heart is getting ischemic, I want all of my other all of the heart getting a good amount of blood. I don't want one part using up a lot of oxygen and this part not getting enough oxygen. So decreasing when a patient has MI, decreasing oxygen demand is one of the most important things. And how do we do that? By decreasing contractility. Make sense? Well, what do we say about contractility? Increased preload causes increased contractility. So how can I decrease contractility? By decreasing preload. When I decrease preload, I don't stretch the heart. And if I don't stretch it, I won't have increased contractility. And that'll decrease the amount of oxygen that's being used up, okay? So when I give a patient with an MI, nitroglycerin, I Vno Dilate. And when I Vno Dilate, I decrease preload. I decrease the venous return, and if I decrease venous return, I decrease the contractility, and I decrease the oxygen demand, okay? That will actually help distribute the oxygen a lot better. That's why nitro is used. It's not because it dilates the coronaries. There are tons of questions on USMLE World and on the USMLE because this is actually a really big misconception that all the students have is, oh, they think that you dilate the coronary, the coronaries and that allows more oxygenation. No, it does do that to some extent, but the main reason why nitro is given is because of this effect here, which I was talking about. Okay, and that's what they want to know, not anything else. Okay, so again, decreasing preload. What's one other thing that can actually decrease preload? That's the Valsalva maneuver. Okay, what is this? This is when you take in a deep breath of air, it's inspiration, and you're bearing down at the same time. So it's more just increasing your intrathoracic pressure. Okay, why does this decrease venous return? The way it does this is because the IVC, the right atrium, all these structures are located in your thorax, okay? If I increase the pressure here all throughout my thorax, what is it going to do? It's going to constrict the IVC. It's going to constrict the right atrium, right? And if I constrict the IVC here, at this point, will it be easier for the blood to come through here or harder? It'll be harder, okay? Because there's such increased pressure here, the blood coming up here, it'll be really hard for it to come back up. Because the right atrium is being squeezed, the IVC here is being squeezed, and the blood can't get back up that easily. That's why the Valsalva maneuver will decrease preload. And the way it does it is increasing the intrathoracic pressure. Okay, so getting back now, the Valsalva, we talked about preload, etc., what increases, decreases it. Why is it important to know what increases and decreases preload? Well, there are first of all, there are a lot of physiology questions where they actually simply ask you what will increase or decrease it. The second thing is, that really shows up a lot are the murmurs. and some murmurs increase intensity with increased preload, some decrease intensity with increased preload, etc. So this is why it's really, really important to know, and I'll go over this in a separate video of how that happens, but that's another reason why it's really important to know that. Okay.